Assalamu alaikum. I'm Dr. Rabia from Anatomy Department, Sahara Medical College. Today, the topic of discussion is back of thigh in gross anatomy, or we can also call it the posterior compartment of thigh or hamstrings compartment. We are going to discuss all the contents of this compartment individually and then the clinical anatomy related to these contents. The diagram is a midsection of thigh, 15 centimeter almost below the inguinal ligament, and it shows the cut section of femur here. And then we can see the region of linea aspera here, and the three main septa arising from facial atta and inserting on the linea aspera, medial lip, lateral lip, and the intermediate region are the medial, lateral, and posterior intermuscular septum. Here we can see the medial intermuscular septum, and then we can see the lateral intermuscular septum here, and then the posterior intermuscular septum here. These septa separate anterior compartment of thigh. Here you can see all the muscles: rectus femoris, vastus medialis, intermedius, lateralis. And then we can see the medial compartment of thigh, including gracilis, adductor longus, brevis, and magnus. Then we can see the posterior compartment of thigh, which are hamstrings, here shown by biceps femoris. Then semitendinosus. Semimembranosus is not shown here. Part of adductor magnus is also in the hamstrings. And then you can see a main content, a large nerve, the sciatic nerve. So again, enumerating the contents of posterior compartment of thigh, we include hamstring muscles. Here you can see biceps femoris, semitendinosus, semimembranosus, and ischial part or hamstring part of adductor magnus. Then we have the arteries supplying the posterior compartment, mainly branches of deep femoral artery or profunda femoris artery. Then we have the nerve, which is the largest nerve of the body, the sciatic nerve. Now, as discussed in KLM, hamstrings have some common properties, and their proximal attachment is from ischial tuberosity mainly, and exception is the short head of biceps femoris, which is arising from the femur. Other than that, semitendinosus, semimembranosus, and the long head of biceps femoris and the hamstring part of adductor magnus, they all are arising from tibial tuberosity. Now, they are inserted on the bone of leg, mainly lateral hamstrings are inserted on the fibula, while the medial hamstrings are inserted over tibia. Again, we have an exception that adductor magnus does not cross knee and it is inserted on the adductor tubercle. Then the innervation of hamstring is from the tibial part of sciatic nerve. Here there is another exception, biceps femoris, short head supplied by common peroneal nerve or common fibular nerve, while long head is supplied by the tibial nerve as with the other hamstrings. Now the hamstrings are going to cross two joints, the hip joint and knee joint. So they are going to act on both the joints. If the thigh is fixed or the hip joint is fixed, they are the flexors of knee joint, and if the knee is fixed as in standing condition, they are basically the extensors of hip joint, or if the hip and knee both are fixed, they can extend the trunk. A very important point to remember is that on walking on a smooth plane, hamstring are basically the active muscles responsible for extension, While on inclined plane and climbing stairs or acting against gravity, we know that gluteus maximus muscle is the main extensor. So standing still or walking on the smooth ground, on a leveled ground, the hamstring muscles are responsible for these postures. Now, talking about the lateral hamstrings first, lateral hamstrings include biceps femoris. It is a two-headed muscle. It has long head and short head. The long head, along with other hamstrings, is arising from ischial tuberosity here, while the short head is an exception and it arises from the linea aspera and close to the lateral lip. Now, insertion of the bicep femoris is on head of fibula. This insertion is interrupted by lateral collateral ligament or fibular collateral ligament, and thus there is an extension from this insertion onto the tibia as well. The long head is supplied with the other hamstrings by the tibial part of sciatic nerve, while the short head is an exception and is supplied by the common fibular part or common peroneal part of the sciatic nerve. Now, the action of biceps femoris with the other hamstrings, as we have discussed, that there is extension of hip, and then if that is hip joint is fixed, then there is flexion of knee. And as this muscle is going from the back of the thigh towards the lateral aspect, contraction of this muscle can also cause rotation of tibia towards the lateral side or rotation of leg towards the lateral side. Of the medial hamstrings, the one lying superficial with a smaller belly here and the long tendon of insertion is the semitendinosus muscle. It is going to take origin from ischial tuberosity. The insertion is on the medial surface of medial condyle and shaft of tibia. Here it is inserted along with two other muscles of anterior and medial compartment of thigh, sartorius, gracilis, and all three are called pes anserinus or gyropes. Being a typical hamstring, it is supplied by the tibial part of sciatic nerve, and it is going to extend the hip joint, flex the knee joint, and being a medial hamstring, it is a medial rotator of leg at knee joint. Due to its long cord-like tendon, it is named as semitendinosus. The second medial hamstring, which is lying deep to the semitendinosus, is semimembranosus, as its origin is like broad expanded membrane, and it is a broad muscle lying deep to semitendinosus, so that's why it is called semimembranosus. Origin is from ischial tuberosity, and insertion has some specific points. At one part of insertion mainly is on the posterior aspect of medial condyle of tibia, here shown as semimembranosus tendon. Some fibers are reflected from the tendon and are inserted on the popliteal fascia, which are not clearly shown here. And the third point is that some fibers of semimembranosus tendon are reflected from here and are inserted on the capsule of knee joint on the posterior aspect, and here you can see them. They are called oblique popliteal ligament. Semimembranosus is supplied like other hamstrings by tibial portion of sciatic nerve. It extends the thigh at hip joint, it flexes the leg at knee joint, and it is a medial rotator of leg, especially in mid-flexed position. And through oblique popliteal ligament, it is going to reinforce the capsule of knee joint posteriorly. Now, adductor magnus muscle has two parts. The adductor part is arising from the common ischiopubic ramus and inserted on the linea aspera, while the hamstring part, which we're going to discuss here, is arising from ischial tuberosity, you can see here, and then this part is inserted on the adductor tubercle, and the nerve supply of this part is from the tibial part of sciatic nerve, while the adductor part is supplied by obturator nerve. The action of this part is extension of thigh at hip joint, and this muscle is not going to act on knee joint, and there is no rotation produced by this muscle at knee joint. Here we can see that from femoral artery there is a large branch arising called profunda femoris artery, or the deep femoral artery. This artery gives rise to 3 perforating branches, and then is continued as the 4th perforating artery itself. The 4 perforating arteries, they are going to interrupt or perforate the aponeurotic insertion of adductor magnus as seen in this diagram, and then supply the hamstrings. After giving the muscular branches, these perforating arteries are going to anastomose with each other, and then superiorly with the gluteal arteries and inferiorly with the popliteal artery. So you can see that there is a continuous arterial channel formed by the anastomosis of these perforating arteries with each other and with the gluteal arteries and popliteal artery. So there are 2 anastomosis formed between on the back. One is in the gluteal region, which is called trochanteric anastomosis. This anastomosis is formed between the deep branch of superior gluteal artery and also from the ascending branches of medial and lateral circumflex femoral arteries. Then there is a cross-like anastomosis overlying the region of lesser trochanter. This is called cruciate anastomosis. Superiorly, we have a descending branch from the inferior gluteal artery. Inferiorly, we have an ascending branch from the first perforating artery. Then we have 2 transverse branches from medial and lateral circumflex arteries, and this cross is formed here. Then the third anastomosis is between the perforating arteries, as we have discussed here. All the perforating arteries are connected to each other and also to the popliteal artery by a descending branch here. The superficial and deep venous drainage of lower limb and the lymphatic drainage will be discussed in details separately. The superficial veins drain into 2 large veins, the great saphenous vein and the small saphenous vein, while the deep veins here in the thigh, you can see, are forming the profunda femoris vein, the deep vein of thigh, and this is going to be drained in femoral vein. The femoral vein is going to be drained in external iliac vein and through common iliac vein to inferior vena cava. And the lymphatic drainage is also superficial to the superficial inguinal lymph node, and the deep is to the iliac lymph nodes. The cutaneous innervation of this back of thigh is through posterior cutaneous nerve of thigh, which arises from the sacral plexus, the anterior rami of S1, S2, S3, as previously discussed with the sacral plexus. The posterior cutaneous nerve enters the gluteal region through greater sciatic foramen inferior to piriformis muscle, and then it enters the back of thigh, where it pierces the fascia lata to innervate the back of thigh. The main part here shown in purple is supplied by the posterior cutaneous nerve of thigh, while some parts on the medial side is extended onto the back of thigh from the obturator nerve, and some cutaneous branches from the lateral cutaneous nerve of thigh also extended from the lateral to posterior side. Other than that, the posterior cutaneous nerve of thigh also supplies the inferior quadrant of gluteal region, as we can see here. Now we discuss the most important nerve or most important structure of lower limb, which is going to be present in the back of thigh, the sciatic nerve.
On our YouTube channel, we have coverage of pathology and physiology, and a growing collection of pharmacology. Try it free today.
Sciatica is a condition where there's pain that starts in the lower back, which then travels down the leg. Since the pain is associated with injury or compression of the sciatic nerve and follows the path of the sciatic nerve, it makes sense to name it sciatica. The sciatic nerve is the longest and widest nerve in the body. It's formed by the spinal nerves L4, L5, and S1, 2, and 3, which leave the spinal canal through the intervertebral foramen, an opening located between the vertebrae and behind the intervertebral discs. These nerves travel to the area in front of the sacrum and join to make the sacral plexus. All the nerves in the plexus, except S3, are split into two divisions, anterior and posterior. Anterior divisions of the L4, L5, S1, S2, and the entire S3 nerve create the tibial nerve, while posterior divisions of the L4, L5, S1, and S2 form the common fibular nerve. These two nerves are bound together by connective tissue and make up the sciatic nerve. The sciatic nerve then passes beneath the piriformis muscle and through the greater sciatic foramen, which is an opening formed by the pelvic bone, sacrospinous, and sacrotuberous ligaments. It then travels down the back of the thigh to the back of the knee, where it splits into the tibial and common fibular nerves. The sciatic nerve innervates the muscles in the back of the thigh. The tibial nerve innervates the muscles of the posterior compartment of the leg and intrinsic flexors of the foot. The common fibular nerve is in charge of the muscles in the anterior and lateral compartments of the leg and intrinsic extensors of the foot. Now, each spinal nerve is in charge of the sensation of a specific area of the skin, called a dermatome. Dermatomes of the spinal nerves of the sacral plexus cover almost the entire surface of the thigh, leg, and foot. L4 covers the medial side of the leg, L5 covers the lateral side, S1 covers part of the dorsum and the entire sole of the foot, S2 covers the back of the leg, while S3 covers the back of the thigh. Skin sensations like touch, temperature, pain, and pressure are carried to the spinal cord and then to the brain, where we register the sensations. Sciatica occurs when there's irritation to any part of the sciatic nerve or the spinal nerves that form it. The causes of sciatica can be divided into two groups, spinal and non-spinal. Spinal causes are related, obviously, to the spinal column. The most common one is intervertebral disc herniation. The intervertebral discs lie between vertebrae and act as shock absorbers. Each disc is made of two parts, the outer fibrous ring, called the annulus fibrosus, and the inner gel-like pulp, called the nucleus pulposus. Poor posture, traumas, physical activity, and strong rotational movement can cause herniation where the disc bulges out in one direction. If it bulges out towards the center of the spinal cord, it could compress multiple nerve roots on both sides, or laterally, compressing one nerve root on one side. In some cases, the nucleus macrophages attack the nucleus pulposus and start secreting inflammatory cytokines, like tumor necrosis factor alpha and interleukin 1 and interleukin 6. The inflammation and swelling which result from this reaction compresses the nerves even further. Another cause of nerve compression is spinal stenosis, which is the narrowing of the spinal canal or intervertebral foramen. This is often due to degenerative disorders of the bone, trauma, or inflammatory diseases like rheumatoid arthritis. Spondylolisthesis is a condition where one vertebra slips or becomes displaced due to a trauma, surgery, or degenerative spinal disease and presses on the nearby nerve roots. Finally, any growths within the spinal canal, like tumor, cysts, or abscesses, can cause compression of the spinal nerves. Non-spinal causes occur outside of the spinal region and cause compression or damage to the sciatic nerve itself. The most common one is piriformis syndrome. The piriformis muscle and sciatic nerve are very close to each other. So, if the piriformis muscle gets irritated, it can cause muscle inflammation or muscle spasms that can compress the sciatic nerve. A more recent phenomenon is the so-called wallet sciatica, or credit carditis. Many people carry their wallets or other objects in their back pockets. So when they sit down, these objects put pressure on the gluteal muscles, which compress the sciatic nerve, causing sciatica. Pregnancy is another potential cause of sciatica. When sitting, the fetal head presses down on the sciatic nerve, on the area just before it exits the pelvis. Other non-spinal causes include trauma to the leg and pelvic tumors, which can damage or compress the nerve directly. In sciatica, the main symptom is aching and sharp leg pain. It radiates along the middle or lower buttock, and on the back or the outer side of the thigh. Below the knee, the pain usually follows the dermatome distribution. For example, if the L4 nerve root is compressed, the pain would radiate alongside the medial side of the leg. If the S2 nerve root is compressed, the pain would mostly be felt along the back of the leg. This pain could begin suddenly, usually with disc herniation, piriformis syndrome, or trauma. It could also develop slowly, like if it's caused by a tumor or spinal stenosis, where the pain increases over time. Sciatic pain is typically unilateral, meaning it's only located on one side. Bilateral sciatica, where both legs are affected, can occur with central disc herniation, lumbar stenosis, or spondylolisthesis. Sometimes the pain can be accompanied by other sensory or motor dysfunctions like numbness, motor weakness, and reduction or loss of reflexes. S1 spinal nerve compression affects the ankle jerk reflex, while L4 nerve compression affects the knee jerk reflex. To diagnose sciatica, there are some classic physical exam findings. The Laseg's sign, also called the straight leg raise test, is most often used to check for spinal causes. In this test, a person lays down on their back and an examiner lifts each leg with the knee straight. This stretches the nerve roots over the herniated disc or the object causing compression. If the sciatic pain worsens when the legs are between 30 and 70 degrees, the test is positive. Finally, a CT or MRI should be done to look for the cause. Sciatic pain caused by inflammation often resolves on its own over time. With pain medication and anti-inflammatories, the pain can be relieved in a few weeks to a few months. Surgical treatment is required if the sciatica was caused by tumors, cysts, abscesses, or injury to the spinal cord. Alright, as a quick recap. Sciatica refers to aching and sharp leg pains that radiate below the knee. It is caused by irritation or damage to the sciatic nerve and spinal nerve roots of the sacral plexus, most commonly as a result of disc herniation. Typically, the pain resolves on its own over a few weeks to months, but sometimes surgery is required.
Thanks for watching.
A quick recap of sciatic nerve. The origin of sciatic nerve is from sacral plexus. You can see here the combined root value is L4, L5, S1, S2, S3. And you can see that the anterior divisions of the primary rami of L4, L5, S1, S2, S3, all of them give origin to tibial part of sciatic nerve, while posterior divisions of the anterior rami L4, L5, S1 and S2 gives origin to common fibular part. S3 is completely part of tibial nerve. So sciatic nerve is the largest branch of sacral plexus and it is the largest and thickest nerve of the body. In pelvis, you can see the location of sciatic nerve and sacral plexus. Here, the anterior rami are emerging from the pelvic foramina and they are making sciatic nerve here. and then sciatic nerve is going to pass above the piriformis to exit the greater sciatic foramen. Sciatic nerve leaves the pelvis by passing through the greater sciatic foramen below the piriformis, and then in the gluteal region it is lying midway between the greater trochanter and ischial tuberosity, and it is lying superficial or posterior to the short rotators, while it is lying deep or under cover of gluteus maximus muscle. And then in the back of thigh it is lying on adductor magnus muscle, or it is posterior to the adductor magnus muscle, and part of it is overlapped by the long head of biceps femoris. Here it is removed, and at the superior angle of popliteal fossa, the sciatic nerve is going to be divided into its terminal branches, the tibial part, which is going towards the posterior compartment, and then the common fibular part, which is winding around the neck of fibula. Here we'll only discuss the distribution of sciatic nerve in thigh. The rest of its distribution will be discussed with the leg. In thigh, there is no cutaneous distribution of sciatic nerve, but muscles of posterior compartment of thigh, that are hamstrings, are supplied by sciatic nerve. Here the hamstring part of adductor magnus, the long head of biceps femoris, the semitendinosus and semimembranosus is supplied by the tibial part, while the short head of biceps femoris is supplied by the common peroneal part of sciatic nerve. As discussed in the video previously shown, that there are many causes of sciatic nerve injury, most frequently injured by a wrongly placed intramuscular injection in the gluteal region, and the safe area is in the upper outer quadrant of the buttock, and as the common peroneal nerve lies superficial in the packed sciatic nerve, it is more frequently damaged and results in foot drop. Other causes are also posterior dislocation of hip joint, as you can see occurring in this trauma. The spinal causes have already been discussed. Mainly lumbar disc herniation is a cause of sciatica also. Effects of sciatic nerve include motor injury. There is wasting of the muscles supplied by sciatic nerve, especially below the knee, the leg muscles, and the muscles of the posterior compartment of thigh are paralyzed, but gluteus maximus is intact, so there is weak extension of hip, and sartorius gracilis are intact, so there is weak flexion of knee. Then we can see in the diagram here that with the paralyzed muscles, when the patient lifts the foot, there is no dorsiflexion, or there is foot drop causing a stamping gait. As sciatic nerve is not supplying the skin of thigh, the loss of sensation of skin is below the knee, except for this blue area on the medial side of leg, and down up to the medial border of foot up to big toe. This area is supplied by the saphenous nerve, which is a branch of femoral nerve. Other than that, all the cutaneous innervation of the leg will be non-intact. As discussed before, sciatica is the pain that is experienced on the buttocks and posterior aspect of thigh and leg, especially on the lateral side of leg. And this pain is a result from compression or injury to sciatic nerve. Here again, we can identify the various causes of sciatica. We can see a prolapse of an intervertebral lumbar disc and pressure on the roots of lumbar and spinal sacral plexus. Then we have an intrapelvic tumor, which is causing pressure on the sciatic nerve arising from the sacral plexus. And then here, direct inflammation or injury of sciatic nerve results in sciatica. Another important clinical aspect is hamstring injuries and the posterior compartment of thigh. Hamstring injuries are related to the injuries of hip joint, and you can see here it usually occurs in footballers and basketball players with sudden jerky flexion and extension of hip joint. You can see hamstring can tear off from their origin, and we can also see fracture of ischial tuberosity by the pull of hamstrings.